Ahizoba rya kabiri mu rukiko rw'abakozi b'iby'amagara aba Kigezi Yona Kigezi Annual Performance Joint Review Meeting. Kanungu Express TV twakuletera bikuru ebigambigweho mu rukiko mu kuronda buryo obuhamire obwo kutereza embera y'eby'amagara.
Twija nka Ministry of Health kwetaba mu rukiko w'abakozi b'iby'amagara n'abakawo aba districts zo muri Kigezi districts mukaga.
To make generic messages, okay, and IEC materials that the district would start on. But currently, I don't know when this has been done, because what the department, why is it as division of health promotion, is doing ad hoc. They only prepare for mpox, they only prepare for malaria campaign. So in short, they're only interested in the juice programs.
When you're a health center for, you get the standard. Now, whatever you get extra to that is performance-based. And that was the intention. And it has been institutionalized. Actually, this morning I had an interaction with your very own, some of your very own in charges. Others are getting 50 million per quarter. Others are getting, I was in this one where they're getting 25. Others are getting 30. So PHC is no longer one shoe fits all.
Okay. These are general discussion.
Caretakers to buy the drugs. So my humble appeal and request, Mr. Commissioner, can we be able to influence the national medical stores to change their procurement plans and add IV paracetamol in the next procurement cycle? Thank you.
Okay, thank you. Rwanda actually submitted of how they are trying to do it. They are subject to questions in what you're doing, especially utilizing the health center tools in screening and tracking these mothers as low as at health center 2 level, because it sounds a working model at the end of the day. And I want to propose, because this could be a policy thing at the end of it all, such that, because my challenge with him is how do they access, for example, surprise in terms of the XCG kits? Because health center tools receive what we call a defined kit. It is fixed in a way that it has specific items that they receive. And inclusively, there are no XCG kits. But we could agree in this meeting that we functionalize this approach of testing every mother. Of course, once you miss your first maybe period, at the end of the day, you get into, you have 1 month amenorrhea, you go to attend care at health center 2, and they do point of care testing at the end of it all. They get your urine sample, subject it to an XCG, and we want to know whether you're pregnant, such that immediately they discover you're pregnant. Probably if that facility has no midwife, then you're referred respectively to health center 3 to kick off with antenatal care.
Yes, the commissioner had said it, that every appointment is based on availability of wage and position. But if we can recall, or if we can revisit our files, when an employee is going for leave, there is a form which is attached to the bonding agreements. The accounting officer has to attest that this person, if he goes, coming back with this qualification, he or she can be absorbed. So this calls for regulation of training. Or before they sign an agreement, if you see that this cadre is at its it is filled to the maximum, then the employee should know that if he comes back, he can't be absorbed within that entity.
Also that they require is the payroll register for July and August. They also require those ones who are recruited in the 24-25 but have not yet accessed the payroll and they have clearance. And then also those that are on interdiction and half pay, that information. Then clearance will be given this month of September.
Okay, thank you. I don't hold the commission.
Amalgamation of all the data from the districts too. My comment is on high screening rates for nutrition, especially in Rwanda and Ruchiga. They performed best on this indicator, okay, for out of the 6 districts. However, what we see at the regional referral hospital is that most of our malnutrition cases are actually coming from Rwanda. And so I want to call upon Rwanda District. Yes, you are doing the screening, which is good, but I think you need, I saw most of your indicators in community initiatives in red. Maybe there's something that you need to do in the community to ensure that these ones turn from red to green. And maybe in that way, you'd be able to deal with your malnutrition that end up at the regional referral.
The scans for scanning them, the HCGs, unless we go to the community and we tell them the importance of RNC so that when she misses the period, she comes. We'll never improve it. Thank you very much.
Thank you very much. Thank you. Very important message.
Thank you, Commissioner. My comment is on the digitalization. We are requesting Ministry to give us a roadmap. So far, we know that you have reached hospitals. So when are you reaching health center force? Because currently we have stock out of many tools and we are stuck as biostats. And at health center too, we are not sure when the digitalization is going to happen. But currently we have stock out of OPD register. So if we keep moving like this, are we going to have the quality of data that has brought us here? Thank you very much. Always communicate to district or through DHO that can reach the biostat and we know what is happening. Currently, we don't know what is happening with the tools, with the digitalization. Thank you very much.
Going digital. We don't know where we shall get money to buy the digital tools because you also need a tablet or a phone. But if we give you a system that you can put on your phone, biostats, you all have phones. Maybe we facilitate you with some little data. But for the beginning, it's going to be a tough transition. I just need to prepare you for this. It's a reality, it's going to be a tough transition, but we must be ready. We need the data for planning. We need the data for management. Sometimes it's very good to be honest. Coming, but things, people who are doing this work should have planned better at a certain point. So that puts to bed the issue of digitalization. Next week, you'll see, I will post the letter myself. I'm going to draft for PS what to communicate and in consultation with the Department for Data.
Going to come. So if we get stuck into our old system, we cannot move. Let's just embrace that change comes. It will come with the challenges, but it is the right way and the best way to go.
The transition.
Yes, let's just have a positive mind about it.
The letter will describe the transition.
Thank you.
Describe the transition. But first and foremost, don't panic. I now want to speak like an RDC. Government is in control. Don't panic, money will come. So tools will come. Really implementation perspective, that the issue of not having mothers coming in the first 12 weeks or 3 months is an issue of message packaging. The moment we tell these mothers in churches, in markets, wherever they are aggregating, that if you don't come in the first 12 weeks, this is the critical time when your baby is developing. Any abnormality is likely, including loss of the pregnancy, if the mother is not screened. HCG will not change much because it's at the service delivery point. HCG is part of the supply side. But at the demand level, we need to be very intentional with our message package. Very simple. All the problems you are seeing of your baby on your baby is because you didn't come in the first 12 weeks, and they will come. Of course, also trying to map out those areas that have a special focus. Now, in our new plan, and I had shared with Paksha, we have a special consideration for hard-to-reach areas, mountainous. We've actually picked this from Muku, your place. We have a waiting shed in the plans for the health centers that are in hard-to-reach areas. Of course, not Rukunjiri. But these ones in the mountainous, this one has mountains, they had Bulambuli. So the mothers will be having waiting sheds. They are part of the infrastructure design. So moving forward, and we have a project that's going to look at infrastructure. We have, we are going to put on top of what the standard structure has been, we have that in place. that's going to put up a maternity. Please use the Ministry of Health plan, because we don't want you to keep building and breaking. You have little money, but use the money. At least we shall give the phased approach. And immediately you begin construction. Right to the PS so that the planning cycle that begins in September, we give you more money to do the phased construction. Please, can that be done from Ruchiga? Cow is not here. DHO, you're here. Please do that. I don't think it needs a question.
Expand.
So you don't need more money.
No,
good luck.
More money is now Minister has failed to construct the PS in 2023 promised to construct a new theater at Imparo, because the other one has the sagging floor. Actually, anytime the doctor is here, anytime you can cause infection.
Please,
now
get me that report.
I have even letters I can give you anytime.
I will go with them.
She promised to have a transition fund for construction of the theater up to now.
Now, how the ministry works? And this equipment that you've been hearing, the distribution, this doesn't even know. I sit down with the guys in the infrastructure. I say, this Imparo needs this one, Kasima needs this. Please give me the copies, right to the PS.
I have 2 copies.
You cannot be happy. So let's not move without Ruchiga on board. That's my request.
Patience. Is that one really logical? What type of planning is that one? The service for that was maybe service. Just put on tires that are old. What sort of psychiatric nursing officers at our center force, and they are following them. Yes, the number may be high, but
the CMA. I wasn't ready, but I had my materials. So that proactiveness from the facilities, there was also a very good plaque arrange. Then also, some districts haven't yet integrated this client feedback into their supervision tools. We have a standard one for MemWatch, but it can be customized and include it on your support supervision tools. Then also, some limited buy-in from some stakeholders. It's another bigger challenge. So these are some of the, like the far left, that's one of the DHO's forum meeting, where the hospital, and we are reviewing the dashboard of this client feedback. On the other right side, we're at Kamganguzi, orienting our teams on the RCSFI. As a region, that is our progress. As a region, I categorized it according to districts. Total as a region, we have 162 sites which have so far interviewed 8,000 clients, and of them 74 are satisfied. And they're also broken down across the districts where we see a high satisfaction rate in Rukunjiri at 82% across the 27 sites among the 1,755 clients. And I also, number of clients which are many is Rwanda. Rwanda also has around 1,748 clients, and of them, 80% of them are satisfied. So that's a breakdown, but good to note, the region is all about 50%. So it's not in red, it's in yellow, light yellow, dark yellow, and light green. Broken down according to levels. However, the trend of the graphs is from those that have interviewed they have interviewed that number of clients. The hospitals are 8. They have around 1,400 clients interviewed. The center force are around 23, where they have interviewed around 34 clients, and also how other regions also perform. And I've highlighted it in that red box. So that's the trend of our satisfaction rates, ranging from 76% to 67%. So for this month of August, though not yet over, if you look at the extreme end, Kigezi region, we have a number of factors that are affecting the satisfaction rates, and among them, they are there.
Check on engage communities and reach out and also prevent outbreaks in our communities. The DHOs of Kanungu, Kabale, we have also engaged the DHO of Rwanda up to some extent. This is because we believe that this project makes meaning if we do collaboration with the district health teams. Our project focuses on the area around the Bwindi community area, and this is the big reason is there has been many outbreaks that are happening in Uganda, and most of them are zoonotic. Zoonotic diseases are those that can be transmitted between humans and animals, and there's also reverse zoonosis where humans actually make animals sick. So our project focuses on data capture. We know that if 75% of the diseases that are disturbing us are coming from the animals, then we have to intervene as quickly as possible, especially for the infectious diseases. The region has been going through anthrax outbreak. Recently, we have had Rift Valley happening. We have had a number of outbreaks that have happened, and actually some of them have been devastating. The regional referral hospital, go to slide 3, please. Where foot soldiers are actually the VHTs. So we will be working with the VHTs to empower them to identify and report these zoonotic diseases as they occur. Basic funds. And the reason we suggest that is that around the Bwindi area, or around most of the areas, our VHTs use simple phones. They don't have smartphones. But the technology that we are developing is also able to be easily adaptable to the smartphone. And the VHT does not pay any money. It's a service that the way the project is running is because the picture that I have of the monkey is from Bwindi Community Hospital. Some of the facilities around the Kigezi region are next to the forest, and monkeys can come in, baboons can come in, and it means that they are at risk of picking infections. So that's a patient actually. I am hearing people laughing in the background. That's an pediatric ward, and because Bwindi Community Hospital is at the forest edge, these monkeys come in to scavenge for food. So you don't know if it's going to pick an infection or if the monkey is going to take an infection back to its relatives. Next slide. So we in the mHealth project, we are proposing to use the One Health approach. Empower everybody, work with the veterinarians, work with the data scientists, work with the politicians to ensure that health is prioritized and reported using basic technologies. Next slide. With 500 PhDs over the last 10 years, and we have trained them to do reporting. And if you come to the area of Bwindi, you will find amazing results. But all health information systems that we are talking about need to be adaptive. We are talking of technology that our VHTs may not be able to use. So we have to think under the direction of Dr. Birunji. We had developed what we call the Bwindi, the MGIS, Mobile Community Health Information System, that enables VHTs to report incidences in their communities and report them to the facility, that the facility then sends them into the HMIS system that is sent to the national level. Next. So, how do we decide how are we proposing to approach the Bwindi Health project? One, we want to develop a network that is able to use the basic phone, the Katochi, that's a common phone here, to report incidences within their communities, relay them. If there's an anthrax outbreak, the first people to identify the case are going to be those in the communities. We took 83 days in Kanungu in the last anthrax outbreak to actually find out that there was an anthrax outbreak. Notification should have come, But because some of these systems are not supported, we missed the opportunity and to see how to approach this kind of innovation. The VHTs revealed that they would be willing to use these smartphones because science would encourage us to first go there. Then we did usability testing. Simple messages that VHTs can work with. We realize that if you have a long message for the VHTs, they will not be able to send it. We developed a simple system that enables VHTs to report using a system that looks like USSD. 4 steps to a maximum. Beyond 4 steps, the USSD system is like the one we use for mobile money. You put an instruction, takes it to the next one, takes it to the next one. And then an alert is sent to a center at Windy Community Hospital. Next, please. So that's how the VHT dialogue looks like. They dial in and say, I want to make a report about either human illness or animal illness. We have been able to engage the VHTs, and after actually the phase of constantly working with them to develop the system, we have been able to develop a prototype that can work to do reporting to up to the point we receive an alert in our system, and then the community health nurses actually follow back, and we have been collecting data. Please go back a bit. That's my last slide, the important one. Then we are developing something we call integrated IV nerve system. It's simply put, it is a system that works where you don't have the technology to work with the GPS. So what it does is that it keeps, as the messages keep coming in, heat maps are drawn all over the place. And then it alerts us and tells us, please concentrate on quadrant 6, because we are getting so many alerts from this area, and it looks like we are having an outbreak in animals and an outbreak in humans, which might be an indication of a zoonotic disease outbreak. Then for AB3, we are now doing stakeholder engagement. We want to learn from the veterinary doctors, we want to learn from the politicians, we want to learn from all people outside the health sector, within the health sector, in order to move this agenda forward. This grant was supported through the National Institute of Health. We have survived the recent cut that has happened in the US funding. So we are moving now into the implementation phase, where we'll be doing a lot of data testing. And the primary reason why I want to move into this phase of testing is to see if this technology can work and if it can be expanded to other parts of the country.
It was entered, we learned about it into the system. Then you would have seen most people come from wherever they are to check on and verify whether this is true. I have an example in I think Chegego. They reported a severe AFI. Today we are still investigating, but it is costing us more than I think 80 million so far to be able to verify. But even when you verify, because they did not do a pathological, then the autopsy may not be sufficient enough, and that will cost us more, because if it is a severe AFI, adverse drug reaction following immunization, and this person received DPT and polio at 6 weeks, and now looking at all details required in the investigation, I think DG is on our neck to be able to present. So this
to the responsible entities, those who are MOH and the district local governments. One was to conduct health promotion activities such as radio talk shows and barazas to sensitize the community on drinking, on not drinking untreated water. The status of implementation of these activities, as you see, health promotion activities were implemented in the districts. Some districts were holding one radio talk show on health promotion per quarter. This was basically in Kabale, Rubanda. There were also community-led total sanitation activities that were implemented in all the districts, particularly in Ruchiga. One of the findings was that the public health, the Department of Public Health at general hospitals and regional referral were like not working very well because of inadequate staffing or no staff. And the undertaking was to reinstate doctors or consultants and medical officers special grade who were in post and abolished by default, and also have an MOH regional office to coordinate regional activities. As a consultant who was recruited or who was posted at the station, I think in the last few weeks, about 3 or 4. What is happening in the rest of the general hospitals, we are not very, very sure, apart from Windy, where we also had that the community health department is actually very vibrant. We functionalize the sanction and reward committees for the facilities, and also do get client feedback regarding professional conduct among health workers. Also, the other one was to conduct health service leadership and performance management through supervision. Salary increment versus output. This one needed some bit of research, and nothing much has been actually done to this, but it was a responsibility of the district's Ministry of Health and the regional referral hospital. So we have not yet done those serious surveys to evaluate the impact of the increment on the health service delivery. Because this one has already been highlighted. We had by then a number of health centers that were not functioning. Or theaters, mainly it was the theaters, but as you have heard during the discussions, this is still very good work in progress. You heard when the commissioner and the presenters have been telling you, Lujeyo Health Center 4 theater is under renovation, soon to operate. Lukungiri Health Center for the theater is also under construction. It is complete. So it is about to be operationalized. So that is some good work in progress. You heard about Kakomo, it also received the funds. So that gap, we seem to like almost we are closing it. Were above in the region, were above. Is it okay? And the key thing here of the nutrition status among the children who are under 5 entities are there highlighted, and the recommendation were on to improve nutritional assessment and screening to identify malnourished children in the communities. And this is also work in progress. Previously, I think in the last 3 or 2 months, we have also, at least in the last financial year, we never had stock out of nutritional supplements. We actually almost got some of them. A bit. I've conducted health education on infant feeding and talks on the radio, talk. Oh, we had medical products and supplies inadequate, basically ARVs, EHS were low. Limited HSC data review and use at health facility, and then some management tools. So the recommendations were stock management. The districts have actually done some good work on this. They have implemented some of these recommendations through their routine support supervision to the facilities, as well as through the routine SPAs. Should be the 7th one is the one which so I think that is it, unless when you need some clarification, but that is it.
We have to know that most of our radio stations are local ones. Now, if we go like on radio of Kabale, the Kanungu people will not listen. So it would be better to state the percentage of achievement, saying that Kabale carried out radio talk show and Kisoro, then the Kanungu did not. Then the level of achievement, we know why we are not achieving. Thank you so much.
Secretariat.
Yeah, I think next time is important that is in between there we need to get some to send this to the different either DHOs or the responsible people who are assigned to get some feedback of this. So that by the time now we reach this other meeting, at least we have like a progress report.
Okay. If there is anything that has not been captured, this is the time for us to improve the what? The recommendations and the actions. So that when we come for the fourth GRM, we should have handled the issues we have raised here. Thank you very much.
Okay, Chair, allow me, still work in progress. Okay, the same template that we have used to project the last year's proceedings. It is the same template that we use as a region to generate our actions for our subsequent joint review missions. As I wait for the IT to put the screen up, this has been the third regional annual health sector joint review mission. It has been in Kanungu as a host. The venue has been Goro Cottages. And issue number one, or the key finding, we have begun with the FY26 regional GRM. It's the first key finding. And what will be our undertaking? So far it is still a dash, but we need to have a district to host the GRM for next year. Undertaking number two is to commit and allocate the budget lines for future GRMs. As we were discussing with the Center Force in charges, they said by end of March, they have already worked on their budget. So I don't know how it will be feasible, but way forward, let's commit to allocate the budget for the subsequent future GRMs. Another undertaking on the same issue, kindly increase the font, make it 20, and you will keep moving your screen. So go to issue one, which is coming next year. Then the district, we shall nominate the district before we leave here, and we go knowing we are going to this district. As you all know, we are supposed to be here this year, but in the last 1 week, some funding agents had actually told us to go to Kabale. But by nature of our regional planning, we do it on a rotational basis. So we need to have a minute this year where we want to go next year. So should we go with that? Because I have to update it. Rwanda, next year? The DHO, do you take it up? Yes, clap for it. So update on that XX, put Rwanda District. Remove XX and put Rwanda District to host the next year's GRM. Issue number two, go to issue number two. Scroll issue number two. Issue number two, we have high maintenance costs for the ambulance services and repairs. Here, as a region, we have to advocate this. It has come from us, and the center knows it's a challenge. And we want to regionalize the mechanical garage for ambulance service repairs. Put the next 2 financial years, because may need some other follow-ups. And the director for the regional referral hospital and the DHOs are responsible to push this generalization of the ambulance service and repairs. Issue number 3. Issue number 3, regional collaboration for improved service delivery. The main point here is collaboration, and we see the undertaking will be DHOs and CAOs that have emphasized the Kigezi's unique collaborative approach, where we have been described as allies in service delivery. So we are going to continue and update that action. It is still a working document, but it's one of the key undertaking in this JRM. Issue number 4 is the non-functional health center force. We are going to update them there, as earlier mentioned, all of them across all the districts. And the key action, we have to functionalize all these health center force, that by next year's JRM, at least we have a good progress. As compared...
Why don't we say functionalize already what? Those that are already constructed. Because there are some health center forces that might not be fully what? Where construction has not been completed.
Maybe we can list them.
Yes, let's
Lukunjere has been constructed. Kakoma has got funds. Busanza has been constructed. Rujeyo, I had to have the equipment. There are like some things. It has a theater. Which one? I think only Mpung, which needs construction. You get it? So let it come in all the facilities, because you may leave those who are, you may assume you have already theater constructed and again stay there without equipment even up to next financial year. To me, I want to take it like that, because if we do like only those without theaters, it might only be Mpungu. The rest at least have constructions done. Others are waiting for equipment. We are working together. This is a working document. I see the in-charge Mpungu is saying it is fine. Okay? I proceed. We also found out that we have some counties and sub-counties where there are no health center 3s and 4s respectively. And also have a list of those sub-counties. I'm going to work with the head of the department, Dr. Beda. We have that documented, and already the commissioner has taken that feedback. We're going to maybe get updates along the course of our financial year. Issue number 6, data digitization. Data digitalization, IT, yes. So on that, we see we need to get guidance and roadmap for the digitization. And the commissioner promised is going to follow up with this. IT, kindly scroll the screen. And I don't know, we need to agree together what should be the undertaking for this. Yesterday I heard Dr. Abudoni say we have enough food, and why do we still have malnutrition? So we can agree together to have an undertaking for this, that it is technical. HR?
Nutrition, assistant nutrition officers and health educators to do more of programming and sensitization. There we shall reduce the malnourished children on what. Thank you.
We read more to families so that they be assessing their children. The family read more. Mothers how to be, we give them measuring tips and they be taking their children. It has been supported by UNICEF and it is working for us. So.
It's a need for us to get our political leaders to appreciate that this is a problem. Okay? If they want future voters, they need to encourage these people to grow food. Because I know, however humanitarian we decide to be, even if I had access, I'm not going to donate for an entire village. But if our LC5s, our RDCs, get to know the gravity of this problem, okay? So for me, I would suggest we need either to get our leaders to give them the situation that we have noted there are high malnutrition rates in the districts. We can even quote them accordingly, okay? So that they help us to mobilize. And one of the issues is some families do not even have food. And yet, yes?
Okay, thank you so much. My name is Bob James. I represent Medical Teams International as the team leader, Kanungu. Medical Teams is a faith-based, non-for-profit international NGO. Our areas of operations are across the country, and that's Southwest, Midwest, West Nile. So in Kigezi, we're in 2 refugee host districts. That's Kisoro and then Kanungu. What we're doing in Kigezi are quite, it's actually, we are health implementing partner this side. So we are doing one, disease preparedness, emergency disease preparedness and response. So in case of an outbreak, we actually doing preparation to respond to. That includes outbreaks like Ebola, Mpox. By doing so, we do screening of all people who are entering and leaving the country through the point of entries. So we have staff that are recruited at our point of entries, both in Kanungu and then in Kisoro. Through Kanungu District Local Government and Kisoro District Local Government, we are partnered with health centers like in Kanungu here. We're partnering with Matanda Health Center 3 to provide comprehensive primary health care services, which includes maternal and child health, immunization, nutrition. The same with Nyakabande Health Center 3 in Kisoro. We're also facilitating district on some other areas. Example, we've facilitated in transporting these samples from the diseases of epidemic prone. We take them to the reference lab, like Buera or UVRI Kampala, take examples of Ebola when it's a suspect, Ebola, Mpox, measles. We've also responded to some outbreak, like recently we've known of measles outbreak in Kanungu. That took us about 30 days, and it was done. We had it in April in Kanungu District. So
what happened in our slides, and immunization is not doing well in our region. Some of our districts are still in category 4. Some of our districts are in category 4 because of minor reasons like data issues, which they've been talking about, which we can easily rectify. So we just want to call upon you that where we are able to support, kindly invite us as Warim team. We are doing mentorship and supporting supervision. We shall visit the sites and be able to support those areas. We have seen neonatal deaths and premature deliveries. One of the preventive measures under Ministry of Health is immunization, vaccination. So the moment we don't support vaccination or immunization, the 12, actually right now they are adding even more diseases that we are preventing. Vaccine preventable diseases will continue to attack us. Yesterday we talked about TB in under 5s. 1 out of 3 children of the TBs, and you saw what happened in the presentation, what they showed us. I'm happy that one of the reasons have happened to these children. So I'm just briefly saying that we are seated under his department that will utilize us. Lastly, we are looking at our effectiveness of our vaccines. 84% of our facilities have received fridges, and some of our facilities don't even know how to manage them, how to use the vaccines to store them well. If we don't protect those vaccines, we shall give vaccines that are not potent. We have a cold chain officer who is a vaccine management officer, works with the district cold chain technicians, kindly support them. In addition to the last part of it, we looked at malnutrition. Immunization, one of the other things we are monitoring is growth monitoring and development. Malnutrition is one of the things that we are taking for granted, but I want to assure you that we still have a lot of work to do. kindly invite us in your performance review meetings. Just give us a minute to air out at least the findings in your districts. Thank you very much for your opportunity. Thank you, Director, for allowing us to work with your team in the hospital. Thank you, District DHOs, for supporting us and allowing us to work with your teams. God bless you.
And the choice of this evening that I appear before you to pass a vote of thanks. On behalf of every member, I must say I'm among the excited people because of this arrangement. The arrangement that allows us to come, sit here, of course, in a calm manner when we are not busy at work in the clinical rooms and so on. Of course, a combination of everyone. And we sit and look at our own generated data. And I want to begin there. We must appreciate that we have done too much work. And to begin with, therefore, I want to ask you to join me. We appreciate ourselves for doing a lot of good work. Yes, absolutely. My task is simple: to pass a vote of thanks in every corner. Number one is that we have done a lot. But like you can appreciate, even when we have generated data, we also still, have a lot of gaps. And it was very important to have this regional joint performance review meeting, that we come here, appreciate we are doing a lot, but there is still a lot to do amidst what we are doing. And let's appreciate therefore the designers of this, to the vision holders, whoever came up with this idea, that as a region, once in a while, we should come together and appreciate that we are doing a lot, but we can always improve as far as addressing the gaps are concerned. Let's appreciate the designers of this idea. Join me, we appreciate them. Thank you so much, the vision holders. I am reliably informed this is the third. It has been my first time to attend, but I'm extremely excited. Because beyond this, then we can appreciate what we call evidence-based planning can actually do. We have, displayed our data here. We have identified the bottlenecks anyway. We've been here doing the root cause analysis. What could be the deepest problem in these problems at the end of the day? And so how do we mitigate them? Interventions at the end of the day. And we have, when they were presenting the action plans, we came up with good mitigations. And how I pray therefore that you join me once again. Number one, to thank God for enabling us to have a success. The Lord has been with us. That started with us. Here we have come. We must appreciate. Join me, we combine our hands and appreciate the Lord. Thank you so much. But in ability, both in provision and in all aspects, of course, capacity and plans, worked on and achieved in the name of Jesus. That's my prayer. That's my prayer, friends. Otherwise, just like Papa said in the chair, that he appreciates everybody that contributed to the success of this. To begin with, the organizing committee. Wherever you are, if you are part of the organization of this gathering, you deserve a clap. You deserve a clap for sure. Thank you so much. I know you put in a lot of brains. The output itself shows there was energy spent in this. You were almost disorganized. You got to a point when you were confused. Are we going to Kabale? Are we actually coming to Kanungu? And in the evenings of it all, a conclusion is done that we are coming to Kanungu. So if you can be charged in the evenings of the arrangements that we are coming to your facility and you can give us such an output, why not? You deserve a clap once again. Let's appreciate Kanungu for that. Thank you so much, Kanungu District, the host district. Thank you all the districts for the input. But importantly, thank you for coming. If it was organized to this extent and you didn't appear to consume the services that have been, organized, still we would look angazi at the end of the day. Join me, friends, uniquely to appreciate these DHOs. Yes. Absolutely. That's a very unique clinical room. So on, everybody, the partners, I see you, even you're sticking up to this point. You want to stick to the program and ensure that we come to the end very successfully. This success is not a one-person success. It has been a combination of hands, and we jointly appreciate everyone. Even you, the frontliners, might have what to discuss. Why not finally say then that we appreciate you as well? Join me once again, and we appreciate ourselves for frontlining Because even when we discuss this, you are the input system. But we ate well anyway at the end of the day. We made, that will compensate that. So I appreciate the hotel for the good services and for the space and so on and everything. Finally, I love what the RDC said yesterday, that if you want to stay longer here, even the cow, I think, re-echoed it and say that if you have the ability, have capacity to stay longer here, this district is capable of giving you all that you actually want to experience. It's a good district. If you're staying, we pray for safety. But if you're going back, journey mercies. The Lord is with us. That one that accompanied us here, that brought us here safely, will take us back. I'm not worried at the end of the day. We speak journey mercies upon each and every one of us by the grace of God. Let's go and continue joining effort to save a life. The Lord will surely bless you as you invest your time to ensure that a life is saved somewhere. God bless you.
It's important that we appreciate him, and also the organizing committee. That's the only thing I'm repeating. But most importantly, he said, remind the PNFPs that are taking our oxygen freely. They should give it freely. I hope that is clear. And lastly, I want to wish everyone journey mercies and hope that we shall return to our destinations safely. It's time now, as we are starting, we said it is time for the tire to hit the what? The tarmac. Now it is time for the tire to retire from the tarmac. Thank you.
This time. From yesterday, everything good has been said. Today, everything good has been said. Thanks were given, appreciation, and so on. So what else can I say? But I have one or two things to say. First of all, I want to thank God for the 2 days I've been sitting here. I've really enjoyed everything. Especially I have appreciated the zeal, the commitment you people have exhibited. The presentation. In our days, long ago, before I finished medical school, before some of your mothers were not yet born. And public health was despised. We wanted to win theater or prayer. But now I have learned over time that is the core of business is public health. I have therefore been, my God, I wish, let me not be selfish, but I wish she was my granddaughter. Thank you so much for such elaborate. I've taken long with her. Is she here? Where she has gone. I want to salute the commanders, the DHO fraternity, and thank you so much. Dr. Akasima, if you are not offended, but you remind me of Utafiri, kind Utafiri. I hope I'm not offending you. And then the other one has just spoken, reminds me of either a politician or a preacher. So you people have a lot of potentials around here. We need foot soldiers to be here. We need foot soldiers, as I said yesterday. These are the lower, whom you call lower cadres, but these are foot soldiers, people on the ground who interact with the community. And the purpose is to push the reds into yellow. If we got yellow and we paint Kanungu yellow and Rukunjiri yellow, the 3 R's and the 3 K's yellow, the RDC will be happy. Because they love yellow. Yellow is fair enough, but if you do very well, then you go to green. So we shall need to work out modalities of involving the foot soldiers. I thank God that this JRM has taken place against all odds. Thank you, DHO team, and thank you for your chairman and also your technical head, the director, for sticking to your principles. In fact, never allow people to push you. Because I understand there were some forces that saying let not happen and so on. This thing is very important. This is the third one. And if there were any mistakes that were made, slowly over time, things are going to be better. So keep it up and make sure you don't give it up. This Kigezi chapter is the third one, and this is the way to go. It is long overdue. In Ruchiga, which I'm now becoming very conversant with, they have a proverb say, "Nyenga mache, ayenga mabi." Although I don't believe in alcohol, but nyenga nyenka ayenga, nyenga mache, nyenga nyenka ayenga mabi. In other words, we need to consult one another, sharpen one another in this very difficult situation, where we are called upon to optimize whatever resources you have, to set the balance, to set in scale the balance between optimization in the face of scarcity. Thank you, DHO, for your fraternity, for fighting the good fight. Be naive for health workers think they can. The director called it, is it repairing the fractured lives? Because this health is not manufactured by you. The life is manufactured by God. Let me follow the other preacher who was here. Every time I think of what life is about, and I thank God for World Health Organization, the definition of health, it's not about disease. Health is more than presence of disease. And health is not about medical. Anyway, the World Health Organization is nearer to the truth that actually life belongs to God. There is more than just falling sick and disease and infections, etc. So I want to thank God for this, that when I imagine, every time I am reminded, when I want to be proud and so on, that actually after fertilization, did you know that maybe things have changed since I did embryology long ago, in the 70s? That's when I was doing embryology. And they said, at the age of 26 after fertilization, a thing that looks like a heart starts beating. And then things organize themselves, things are put in place, then the gut is formed. You remember ectoderm, those things, who remembers? And then the thing continues beating. By the time you're about 9 months, it's beating even very fast, above 110. And continues beating up to now, I'm above 70, still beating. It's not because of your jargon is here. There is something more, and that's good. We thank God. But remember, finally, I want to remind you, to appeal to you that you are co-workers with God. To be kind. We have been crying about resources, crying about finances and infrastructure, but there is something that we can not do about ourselves. I appeal to my workers in the hospital to be kind to the patients. You know, if you become kind to a patient, you solve much of their problem. But even if you have a wonderful theater and so on, but you're not kind, you don't show love, you don't show compassion, then you'll be a very, very miserable health worker. I have a doctor who works in my clinic, and he challenges me. He's much more tolerant and more kinder than me. So even when I'm there, I am the one who's qualified. They come and say, and they pass by me. And I sometimes feel embarrassed, but I thank God for him. Do not discredit this profession by soliciting bribes. That's what I'm saying. Thank you so much. Finally, let me invite the RDC. The issues of health cannot be exhausted. Too much. In fact, we can talk and talk and talk. I could see him was having problems. Everyone says something. Is not enough when more is needed. With these few remarks, I want to invite Gan RDC to come and give you a few remarks. But people have already said it is wonderful that you can now cooperate with you, local government and so on. so that we can enact laws and protect our people. We cannot do it alone. Most welcome, sir.
Matters of protocol. So I'll start with the chairman board of Kabale Referral Hospital, regional, the DHOs. Because I'm not seeing chief administrative officers here, I would have I would have added on cows. And all of us participants, good evening, gentlemen and ladies. Yesterday I introduced myself, so tonight I will not. But I want to explain to you why I've said gentlemen and ladies. Because the norm has always been ladies and gentlemen. Can I? When God was creating humanity, He started with a man. And from that man's rib, He created a woman. When they got children, the ones we have heard about, Cain and Abel, now away from that, we are Africans. The African tradition and culture has been patriarchal from time immemorial according to God's setting. It's not our crime. We don't have to be shy about being patriarchal as Africans. Now God did it with a very great intention, a sustainable intention. Sustain the well-being of Africans, but also the existence of humans. Now one time, the whites, so many years ago in the 17th and the 18th something there, became mad and started going into fighting for rights. Then they came up with a feminist agenda. When they came to colonize us, they brought that alongside and hoodwinked our people to think that a woman and a man can be the same. Very impossible. They can only coexist and one supporting the other, but they can't be the same. Am I lying?
True.
We are here, health workers who are female and male. There are areas where a female will not reach.
The same applies to a man.
The same applies areas where a man will not reach. So these two, each one of them has got a role, according to God, but also according to the African culture. Now, when we took up the feminist agenda and moved into this business of gender equity, for us we misinterpreted it. Because it was never our thing to achkwata makushu. And it ended up destroying the African family unit. We are getting destroyed. Now today, some years back, me when I was getting married at 24, as a little boy, I said, I've seen this very beautiful girl in the Okumshre. Now, today, 2025, after how many years, the boys we have are very weak. They fear women. The boys cannot advance, a young man of 25 cannot advance and set a proposal for marriage. They set proposals for an outing, a dance, alcohol, and that's all. And the men, even those who are very strong, able to have 7 wives, are fearing the women. Seriously fearing weakens the African family unit. For us, our strength, the developed world strength is in science and technology, which we are adopting. But for us, our strength in the near future is in our human resource capacity. We cannot build a sound human resource capacity, a sound human resource base when families are disintegrated. A disintegrated family will not raise cultured children. When children are not cultured, they are not able to focus. Control is able to take care of his wife or wives, daughters. Then the boys who are Africanized and believe in our patriarchal society will take care of their sisters, and also the girls they want to marry. So, therefore, we Africans have got to step a little bit back and say, hey, we need to be ladies and gentlemen. Ladies first. That ladies first thing is let us also now make sure that the men advance. When they advance, they do with responsibility. As simple as that. There is no harm in a man standing strong with responsibility. 1, to love and take care of his wife. 2, love and take care of his children, both girls and boys, take them to school, teach each one of them the right morals, and then there we move. Mwachete gereza. So I'm requesting you, whenever you're going to speak to the public, please say, gentlemen and ladies. Then you also explain in that same way. We take this campaign further. It is going to help us. Now let's go to the rest of the team members for this engagement. But one most peculiar aspect of this engagement is that the few minutes I've spent, yesterday I spent a few, even now I've spent a few. My quickest observation is that we are taking health science into the community. It is no longer a myth to an ordinary person. And this makes it much, much, much more better. Because a community that understands the importance of healthcare is the one that will demand for healthcare services. Now I want to appeal to all of us to ensure that we enhance the aspects of health education within the different communities we work, so that these services we're planning to enhance are demanded for by the people we're supposed to serve. It is, for us, our job is to promote government. Now the opposition says the healthcare system is poor. It is not. People have to be flown out of the country. No, it is because they don't go for quality healthcare services at primary level. Sometimes, I think you will bear witness, sometimes we have drugs that expire. Where do they expire? Because our people have not come to the health facilities, the government health facilities. Now, this brings me to the point of kindly begging you, because I know, we have a very, very good country with a free economy. All professions have gone into the private sector. But please, even if you own a private health facility somewhere in town and you work at a certain health center for, first ensure that our villagers access services at the health center for. Those poor ones who consume medicine from medical stores. And then those who have their money and can afford, receive those ones in your clinics. That's okay. Everyone wants to do business. The unfortunate bit is that, now I'm talking about the vices. The unfortunate bit is that quite often we pay attention to our business aspects and then give little attention to public health service, which is not good. I've heard the board chairman telling you that you're doing God's work. And indeed it is. It's God's work. We respect you. We love you. The other vices I want to address to the DHOs. Syndicated incidents of leave. You go to health center X, the in-charge knows that so-and-so is on leave without formal approval. You find like 3 key people are off station. They will tell you this one is on leave, this one is what, and they know how to very, very well explain it. This is not good. Because you see, in the decentralization arrangement, most of these districts, because of political influence, because of influence peddling, recruit children of the soil. Are we together? To primarily look at that which gives you the foundation. and it is your profession and your job. We really appreciate you do us good. I would like to, I don't know whether this was talked about in the rest of the time I was not around, but I think, and I greatly believe that all actors have got to work for, have got to advocate for capacity building and the improvement of capabilities of all our health workers up to the lowest level, so that each time people are discussing experiences, they're discussing from an informed point of view, and therefore our healthcare system can be greatly improved. Health workers in the area of capacity building, especially enhancing their skills. The population of Uganda is increasing, and each time the population is increasing, the need for social services also increases. Basically, health and education. And these are areas that we definitely have got to pay attention to. So I think, Chairman Board, I know you have access to the people I also access, even some of them even better than I may be doing. Let's work together to have this as part of a discussion each time we're discussing about our healthcare system.
ahatari abantu nojya uninka amazina ganjye nibanyita Dr. Richard Mugahi, ninkora nka commissioner w'ebyokuzara kw'abantu n'abaana a Ministry of Health Kampala. Twija aha nka Ministry of Health kwetaba omu rukiiko rw'abakozi b'ebyamagara n'abakaawo aba districts ez'omuri Kigezi, districts 6, Kisoro, Kabale, Rukungiri, Rubanda, Ruchiga, and ezi 6 eza Kigezi. Nankeji meeting eji antujeta joint review mission. Ntwijo meeting omwe to kureba
to make generic messages, okay, and IEC materials that the district would start on. But currently, I don't know when this has been done, because what the department, why is it as division of health promotion, is doing ad hoc. They only prepare for mpox, they only prepare for malaria campaign. So in short, they're only interested in the GSA programs.
When you're a health center 4, you get the standard. Now, whatever you get extra to that is performance based. And that was the intention. And it has been institutionalized. Actually, this morning I had an interaction with your very own, some of your very own in charges. Others are getting 50 million per quarter. Others are getting, I was in this where they're getting 25. Others are getting 30. So PHC is no longer one shoe fits all.
Okay. These are general discussion.
Caretakers to buy the drugs. So my humble appeal and request, Mr. Commissioner, can we be able to influence the national medical stores to change our procurement plans and add IV paracetamol in the next procurement cycle? Thank you.
Okay, thank you. Rwanda actually submitted of how they are trying to do it. They are subject to questions in what you're doing, especially utilizing the health center tools in screening and tracking these mothers as low as at health center 2 level, because it sounds a working model at the end of the day. And I want to propose, because this could be a policy thing at the end of it all, such that, because my challenge with him is how do they access, for example, supplies in terms of the XCG kits? Because health center tools receive what we call a defined kit. It is fixed in a way that it has specific items that they receive. And inclusively, there are no XCG kits. But we could agree in this meeting that we functionalize this approach of testing every mother. Of course, once you miss your first maybe period, at the end of the day, you have 1 month amenorrhea, you go to attend care at health center 2, and they do point of care testing at the end of it all. They get your urine sample, subject it to an XCG, and we want to know whether you're pregnant, such that immediately they discover you're pregnant. Probably if that facility has no midwife, then you're referred respectively to health center 3 to kick off with antenatal care.
Yes, the commissioner had said it, that every appointment is based on availability of wage and position. But if we can recall, or if we can revisit our files, when an employee is going for leave, there is a form which is attached to the bonding agreements. The accounting officer has to attest that this person, if he goes, coming back with this qualification, he or she can be absorbed. So this calls for regulation of training. Or before they sign an agreement, if you see that this cadre is at its it is filled to the maximum, then the employee should know that if he comes back, he can't be absorbed within that entity.
Also that they require is the payroll register for July and August. They also require those ones who are recruited in the 24-25 but have not yet accessed the payroll and they have clearance. And then also those that are on interdiction and half pay, that information. Then clearance will be given this month of September.
Okay, thank you. I don't hold the commission.
Amalgamation of all the data from the districts too. My comment is on high screening rates for nutrition, especially in Rwanda and Ruchiga. They performed best on this indicator, okay, for out of the 6 districts. However, what we see at the regional referral hospital is that most of our malnutrition cases are actually coming from Rwanda. And so I want to call upon Rwanda district. Yes, you are doing the screening, which is good, but I think you need, I saw most of your indicators in community initiatives in red. Maybe there's something that you need to do in the community to ensure that these ones turn from red to green. And maybe in that way, you'd be able to deal with your malnutrition that end up at the regional referral.
The scans for scanning them, the HCGs, unless you go to the community and we tell them the importance of RNs so that when she misses a period, she comes. We'll never improve it. Thank you very much.
Thank you very much. Thank you. Very important message.
Thank you, Commissioner. My comment is on the digitalization. We are requesting Ministry to give us a roadmap. So far, we know that you have reached hospitals. So when are you reaching health center force? Because currently we have stock out of many tools and we are stuck as biostats. And at health center too, we are not sure when the digitalization is going to happen. But currently we have stock out of OPD register. So if we keep moving like this, are we going to have the quality of data that has brought us here? Thank you very much.
Thank you.
always communicate to district or through DHO that can reach the biostat, and we know what is happening. Currently, we don't know what is happening with the tools, with the digitalization.
We post our
Thank you very
concerns on
much.
the group. We never